and says that this system doesn't work. But that's exactly what happens. Actually, it's a small tweak and then you're good to go. All over to you.
So, good morning again. As I said, my name is Hannah Reiband. I'm from Denmark. And currently I'm conducting research in the field of burn injuries at Rigshospitalet. And that's a university hospital in Copenhagen, the capital of Denmark. My presentation today, as said, is about the triage of burn injuries in Denmark and how this might improve by the use of image transferal as a tool in the triage decision. First, I'll introduce you to our study, and then I'll make references to some other studies' results with image referral in burns. So, Denmark, as you see here, is situated in the north of Europe, has around 5.5 million inhabitants. Denmark, here in a bit bigger, it has a lot of coastlines and islands, and ambulance transport can be as long as 5 hours and in some cases not possible. For example, if a burn-injured patient is situated in the north of the country and has to be transported to the burn center here. Therefore, helicopter transport is often needed. Denmark has one national burn center situated where you see the red arrow, and that's in Copenhagen University Hospital where I work. The National Burn Center has to take all severe burns from all over the country, and in total that's around 12,000 burn injuries per year in the whole country. A set of guidelines that describes which burns needs transferal are made to optimize the treatment and to help the personnel that initially treats the patient, and that personnel could be me. So the guidelines, as you see here, involves the burn injuries that dangers the patient's life or future function, as well as those with possible legal consequences. For example, larger burns need fluid resuscitation, and therefore the estimation of the burn is important for the treatment to avoid over or under hydration. Burns to the hands and major joints can reduce the movement of these due to the scar tissuing, and that is if not treated correctly. Suspicion of non-accidental injury is important for the proper documentation. The doctor or ambulance personnel who are the first to treat the burn-injured patient have, in cases of doubt, the possibility to make a telephone conference with a burn specialist at the burn center. This again to optimize treatment, of course, and to make sure that the right patient are transferred to the burn center to avoid over and under referral. So far, store and forward pictures are not normally used in the referral process. So our study is made as an evaluation of the current system of burn triage in Denmark and to look into the experience from other countries and other studies. In our study, we took all patients diagnosed with a burn injury transferred to our burn center in a 3-month period. In total, there were 120 patients. We looked through the patient files, and additional information was collected from the referring hospital if we needed that. We excluded patients that were self-directed to the burn center and those that had a wrongly registered burn diagnosis. So in total, we included 97 patients. The age, sex, etiology and type of burn, referring hospital's description and receiving hospital's description of the burn, the transportation type, and where the patient was transported from and whether they were hospitalized were all registered. Then, comparing this with the guidelines, we evaluated whether the transferal to the burn center was correct. Out of all the included patients, 70% of them had burn injuries which should be treated and thereby transferred to the burn center. Thereby, 30% of the patients were unnecessarily transferred and could have received treatment for the burn injury at the local emergency room. On the bar chart to your right, you see the burn injuries divided into subgroup of burn injury cause. First you have flame, then scalds, contact and explosion. The red color illustrates the overtriage in percent, while the green color the opposite. This is according to the guidelines as I showed you before. As you see here, especially scalds were overtriaged, and scalds were mostly children below the age of 2 years old. You also see that burns due to explosion were all correctly transferred according to the guidelines. We also evaluated the group of 16 patients referred by helicopter with a burn specialist. This because it was the most expensive form for transportation in our study. Considering time of transport compared to the patient age, health, burn injury size, depth, localization, and the need for resuscitation, in total 75% were correctly referred according to the guidelines. But that means, but only 56% needed to be referred by air transport, and 19% could have been transported by ground. And this is because the estimation of the burn injury were wrong, and therefore the need for time saved by air was unnecessary, or transport by ground was still fast enough, considering the burn injury severity. The remaining 25% could have been treated at the local emergency room. So, question rise with our study. Can we implement image transferal for referral of all burn injuries? Should we? Is it beneficial for the patient? And is it safe? Is it beneficial for the healthcare system? And is it easily accessible and easy to use? Is it affordable? In some studies, image transmission as a tool in the decision of burn injury transferal has shown many benefits and been described as a method to reduce overtriage. In Utah, US, in 2009, Saffold et al. Made a case control study including 80 patients and concluded that image transferal used to estimate burn size is practically as accurate as when directly inspected by a specialist, and almost as accurate as face-to-face assessment. In any case, much more accurate than the estimation of a non-specialist. In Turkey in 2010, Turk et al. Made a retrospective study including 187 patients and described the use of image transferal in burn care as appropriate and cost-effective for treatment and follow-up. In the UK, Wallace et al. Made a 12-week prospective study in 2007 and describes the accuracy of triage improved with the use of image transferal in their burn unit. A recent review of Wallace et al. Described the use of image transferal as a tool in the decision of burn transferal as clinically feasible and valid. It's clinically effective and it provides patients with cost savings. So all in all, there is good experience with image transferal in burns. Jones et al. And Saffold et al. Describes in their studies regarding store and forward pictures in burns some risks and benefits. There's a small risk of misdiagnosis. If the picture does not adequately describe the burn injury, it may be under or over-diagnosed. But studies have shown the picture to be very reliable, and together with a telephone conference, you'll be able to describe the burn injury in detail. There will be some extra time consumption, especially in the beginning. There will be time spent on training the personnel needing to use the photo and time used to send the photo, and there may be technical issues. On the other hand, you will have the improved triage. That will save a significant amount of time, and the potential under triage may also be improved. You'll get increased information because the inexperienced doctor or ambulance personnel will get feedback at once and thereby increase the knowledge of burn wounds. To begin with, there will be extra cost. Cost for the photo equipment, the training and extra time used to sending the photo. but fast. It may be cost safe because of the lower transferal expensive. You may have dissatisfied users because there may be startup problems, but the patient satisfaction might improve because the right diagnosis and treatment from the start. So our next step is that we would like to start up a trial with image transferal combined with telephone conference in Denmark to answer the listed questions. Will it improve the triage process? Will there be fewer unnecessary referrals? Will there be fewer cases of doubt? So my take-home messages are: 30% of the transferred patients were unnecessarily referred to the National Burn Center in Denmark in a 3-month period. Store and forward pictures evaluation by a burn surgeon seems to be as good as face-to-face assessment. The use of image transferal of burn injuries in the referral decision has shown to improve the accuracy of triage. This is the end of my presentation. I would like to thank for this opportunity and of course thank the professors and assistant professors back in Denmark that have helped me to come here. Thank you very much.
Thanks, Ray-Ban, for the nice presentation. And now we know in what way technology can actually not only bring down costs, but improve the efficiency and the overall productivity. So 30% of the time of critical care center staff was unnecessarily taken up by something which could have been handled locally. Interesting.